Assalamualaikum.
Waalaikumsalam.
Tak nampak saya, tak boleh nampak kan?
Okey,
Nampak
boleh.
tak lagi?
Nampak dah.
Nampak dah. So, bright sangat. Saya dekat klinik ni. Belakang matahari. Okay, alright. We shall just start lah sebab kita ada 45 minutes kurang macam tu saja. Saya pukul 3 di another event. Kita start dengan kita rapat. Okay, alright. Macam mana you all punya kerja sekolah? Systematic review dah start berjalan?
Dah.
Dah start dah?
Ya.
Okay, ada apa-apa confuse lagi?
Boleh buat second ni.
Okay, alright. So hari ni kita nak sambung kita punya discussion. Okay, boleh dengar saya jelas?
Boleh jelas.
Okay. So kita nak sambung kita punya discussion. So kalau discussion kita pasal case hari tu habis awal, I'll give you another case untuk kita discuss lah. Alright, hari tu kita habis sampai diagnosis kan? Kita habis sampai diagnosis. Okay, can I get someone untuk summarize the case? Lepas tu present mental state sekali. Kat itu kita tak present mental state. So imagine you all dalam walk round lah ni. Okay. So present the case to me. Maybe seorang boleh summarize the case. Seorang lagi present mental state. So siapa? Kalau tak saya panggil nama.
Saya nak try summarize case.
Amin. Alright. Go on.
Patient Andy, 21 years old, university student, final year of his degree, was referred to the psychiatrist for having distressing experience for 2 months. He complained of having second person auditory hallucination and also persecutory delusion for 2 months. At the same time, he also suffered from negative symptoms such as interpersonal relation and then preferred not being in the home. Apart from that, he also mentioned that he took other substances such as smoke weed, about 10 bags, and also speed for 1 week duration.
So how long was the symptom?
2 months. 2 months duration.
Okay, so that's summary. Mental state. Apa mental state? Kita Amin nak sambung dia.
During the consultation, for this patient, he is well dressed but looks stressful. His speech is spontaneous and fluent, but the voice is low with moderate tone.
And before that, kita slow jap satu-satu dulu . So under appearance, apa lagi yang nak cerita?
The way he dressed, the facial expression.
Okay. Remember, bila when you describe appearance ni, you do it as if macam you nak, macam kalau you kena rompak kan, you kena rompak by somebody, then you nak report dekat polis. Takkan you nak cerita, oh dia pakai baju elok, dia bersih, macam tu je. You kena describe it to the point where the next person who listen to your description tu can kind of imagine who this person is as a person. Okay, so saya selalu bagi example like when you want to draw somebody. So when you want to draw somebody, you tak start lukis baju ke tak? You akan start dengan apa? Muka, ataupun you nak start dia punya general structure dia dulu kan? Okay, so start dengan describe him as a person dulu. Dia ni siapa? Male, female, Indian, black, Malay.
Male, what mean?
Sorry?
Male.
Okay. So male, dia punya race dia
English.
Caucasian. Okay. Caucasian tu orang putih lah. So male, Caucasian. Age dia?
21.
Alright. So kalau age in mental state, kita describe apa?
Young.
Okay. So young. Does he appear like 21?
Yes.
Okay. So maknanya kita comment dia appear at stated age. Okay. And because sometimes ada orang yang dia maybe 21 tapi because of the illness tu dia nampak older. And mungkin dia berjambang, beruban, nampak tak terurus sampai dia tak nampak macam orang 21 pun. Okay, so that's something that you can describe dalam your appearance. Okay, and then body build.
White. Large.
Sorry?
Large body build.
Large. Large ni you nak kata dia overweight. Body weight ni sama ada cachexic, underweight, normal, overweight, obese. Yang mana?
Normal.
Okay. Ataupun you nak describe dia ada abnormal body build ke. Contohnya dia ada dwarfism ke, ataupun extremely tall, maybe ada Marfan syndrome ke, then you describe it under body build lah. Okay. Lagi? So body build lagi. Dan baru you describe dia punya external appearance. Okay. So tadi male, Caucasian, age semua tu is dia punya structure dia as a person lah. Okay. So dia punya appearance apa kita nak komen?
He look messy or well dressed.
Okay, alright. So kita nak complain dia punya grooming, ada dua benda. Satu hygiene, kedua grooming. Okay, so hygiene ni bersih tak bersih lah. And so kalau normal hygiene, I mean just like any other regular person yang normal lah. So kalau poor hygiene tu, you kena describe further. So apa indikator yang menyebabkan you rasa dia ada poor hygiene. Lepas tu grooming ni is dia punya additional. So hygiene ni basic. Grooming ni apa dia pakai, sikat tak sikat, dia punya jambang dia terurus tak terurus, dia punya alright. That's dia punya dressing lah. Right, and then apa lagi under appearance? Facial expression, okay. Facial expression, sekali dengan facial expression ada apa? Sorry? Tak dengar? Mood? Bukan. Okay. And tak apa, kita start dekat facial expression dulu dan kita masuk behavior later. Alright, so facial expression. And then, so that's appearance. So, maknanya banyak sikit lah. Tadi Hami just start dengan dia punya hygiene saja. But now ada a few things, additional things that you have to describe. So kalau in exam, mental state ni is one of the things that we look for dalam you punya assessment sebab it basically covers your parts of your examination lah. And sebab in psychiatry kita tak ada examination, so we won't assess you punya auscultation, palpitation semua tu, tapi kita nak assess your observation by presenting your mental state assessment tu more thoroughly lah. Okay, behavior. So under behavior apa yang kita present?
Speech.
Sorry?
Speech.
Speech lah.
Body language.
Body language, okay. Lagi?
Eye contact.
Okay, eye contact lagi.
Facial expression bukan bawah behavior kata. Tu
Under appearance pun boleh, under behavior pun boleh. Okay. Lagi? Apa lagi another example of social behavior?
Abnormal movement of posture.
So nak senang ingat, you bahagikan. So pertama, dalam behavior ni pertama ada general behavior. So general behavior ni is macam mana dia duduk ke, dia melompat ke, dia mundar-mandir ke. And so macam mana dia punya general behavior during interview. And second, you focus on dia punya social behavior. And so social behavior tu eye contact, your cooperativeness, dia hostile ke tak hostile, dia rapport you dengan dia, so social connectedness. So you comment that during the interview. Number 3, you comment specifically on movement because that's under behavior juga. Alright. So movement ni sama ada you nak describe the general movement yang ada apa-apa ataupun you nak describe specifically any abnormal movement yang you noted lah. So abnormal movement in psychiatry ni can be 2 things. Okay. So number 1 is it's part of the disorder. So contohnya apa contoh abnormal movement yang part of disorder? Apa example dia?
Tremors in Parkinson. Sorry.
Kalau psychiatry. Apa contoh abnormal movement yang part of the diagnostic criteria for the disorder itself? Kalau schizophrenia, apa abnormal movement that you would expect to see in patient with schizophrenia? Apa? Catatonic. Good. Okay, so apa contoh example of catatonic behavior? Apa contoh catatonic symptom yang manifest in movement? You all pernah tengok catatonia ke tak? You all pernah tengok catatonia ke tak? Tak pernah. You all pernah jumpa perkataan catatonia ke tak sepanjang you buat psychiatry 2 minggu ni?
Pernah.
Pernah.
Okay.
Jadi tak ada rasa nak Google macam mana catatonia tu look like. Memanglah you tak tengok ward. Tapi benda tu at your fingertips sahaja. You have to have curiosity lah. Kalau tak you all baca catatonia dekat DSM-5, dekat seminar lecture notes schizophrenia tu, you all bayang apa? Macam mana you all boleh relate dengan apa you all study kalau you all tak tengok? Kalau you all belajar dermatology tapi tak pernah Google image, you won't get it lah. And so Google lah. And bukan susah pun. I cannot show you catatonia in ward. I have patient with catatonia in the ward now, tapi I cannot show you. Tapi you all have access to internet, and you should take effort lah and Google je, kat YouTube ada. And so you'll see some examples. Masa mental state lecture sepatutnya you have seen some examples of macam mana catatonia. So for example, an abnormal posturing, and so patient diri tak gerak-gerak and waxy flexibility, held in a different abnormal posture, grimacing, abnormal facial expression. So those are examples of movement disorders yang manifest in catatonia. Kalau depression, apa abnormal movement yang you would expect? Kalau depression. Does depression affect movement ke tak? Yes or no?
Yes, patient ada psychomotor retardation.
Okay. So psychomotor retardation tu apa? True, correct? Psychomotor retardation tu apa?
Dia ada slowness of the movement.
So slowness of movement. And contohnya macam kalau you ajak dia masuk bilik, so daripada pintu nak ke kerusi tu, it may take 5-10 minutes. And ataupun dia duduk depan you bercakap tu tunduk, abnormal stooping, stooping postures, and tak ada eye contact, and then almost immobile, and tak ada langsung hand gestures, and so that's psychomotor retardation. So reduce in motor activities yang synchronized dengan psychological state of mind, which is depressed, so that we call it psychomotor retardation. Can it be the other way? Can it be agitation, psychomotor agitation? Boleh ke tak orang ada depression, ada psychomotor agitation?
Boleh kalau dia manic.
Kalau dia depression, soalan saya. Kalau manic, of course, they can present with psychomotor agitation. Kalau dia depressed, boleh tak present dengan psychomotor agitation? Boleh ke tak boleh? Dua je pilihan je, boleh ke tak boleh?
Boleh.
Okay. So it can still be possible, because in depression you can get depression with anxious distress, for example. Somebody who's depressed at the same time anxious. Okay. Ataupun patients yang depression psychotic, and suara tu disturb dia and menyebabkan dia agitated. They can also present with psychomotor agitation. Or patient presented with depression and tapi ada suicidal ideation. So the suicidal thoughts will make them become distressed. So they are distressed by the suicidal thoughts. So they can present in that way as well. So it's sebab tu important untuk kita describe mental state properly, and because you may get 10 depressed patient, but 10 ni may have different set of mental state, and ada yang agitated, ada yang psychomotor agitation, ada yang catatonic, ada yang ada slowness, ada yang nampak normal behavior wise. So they can present differently. So number one is the abnormal movement tu part of dia punya part of dia punya abnormal movement tu. Sekejap, ada call. Hello. Salah. Sorry. Siapa ni? Saya tengah kelas. Syambi. Kenapa? Boleh je. Kenapa? Sibuk eh? Kau ambil apa? I see. Tak apa. Nanti kita tengok boleh. Tapi dia follow up ke tak? Terapi jalan tak? Penawar. Okay. Tak apa. STAA. Sebab buat sub sekarang. Kalau boleh, tapi kena refer, tapi boleh je. Tak apalah, nanti aku message lah. Tak apa. Alright. Sorry. Kat mana kita tadi? Saya cakap apa tadi?
Depression boleh ada excitatory
Bukan. So the first one is the psychomotor activities, the abnormal movement tu part of the disorder. Second one, abnormal movement tu part of side effects of the treatment. And so apa contohnya? Macam contohnya you get tremor and from antipsychotic. You get extrapyramidal symptom. Extrapyramidal symptom ni can be tremor, rigidity, bradykinesia macam Parkinson-like syndrome. And so, or akinesia. So these are the three things that you need to describe. Okay, so for this patient, behavior dia macam mana? How would you describe dia punya behavior? So generally, macam mana behavior dia during the interview? What can you describe?
Patient appears distracted and worries with
Okay, good.
constantly fidgeting his fingers with poor eye contact.
Okay. Was there any abnormal movement noted apart from fidgety tu?
No.
Tak ada kan? Okay, so there's no other abnormal movement like catatonia or tremor or rigidity or anything of that sort lah. Okay, so that's under behavior. Macam mana dia punya social behavior lah? How do we describe dia punya level of cooperativeness, rapport?
Very cooperative.
Lagi?
Good rapport.
Good rapport. Okay, so I would say the same as well. So even though dia ada poor insight, tapi overall he was responding to questions, willing to answer. Tak ada signs macam dia nak leaving the seats ataupun wanting to shorten the interview. So nothing like that lah. Okay. So patients also presented dengan persecutory delusion kan. And so kalau under persecutory delusion, apa yang behavior orang yang ada paranoid or persecutory delusion may manifest? For somebody yang ada symptoms yang dia experience ni, apa lagi yang you expect untuk ada tapi maybe dia tak ada. So it's still worth to mention as a negative relevance. Does it appear to be suspicious?
To the doctor, not so much. Not so much suspicious to the doctor.
Okay. And tapi ada tak any gestures yang suggest there might be some level of suspicion? Dan apa contoh dia? Kalau orang suspicious dia macam mana?
Yeah,
Dia
frowning.
tunjuk macam mana? Okay, lagi? Frowning tu macam more sebab dia distress kan? Lagi?
They look around every once in a while.
So kita panggil scanning. Scanning, dia scan, dia tengok apa yang ada. Ataupun suspicious behavior, contohnya kalau doktor tu menulis ke apa ke, and dia akan macam tunjuk, minta kita tunjuk, tanya apa kita buat, and kenapa kita nak buat, and ataupun ada setengah-setengah patient yang very paranoid, dia akan macam suruh kunci pintu, and suruh tunjuk telefon, and so this can happen. Okay, this can happen. Alright. So bila mental state ni, dia number one is you have to know apa template general dia. Nombor dua, you kena highlight apa yang ada. Nombor tiga, you kena mention apa benda yang expected untuk ada tapi tak ada. So you don't have to mention everything under each of that domain tu. Tapi sometimes kita panggil dia negative relevance. And so negative relevance ni penting. Contohnya macam kalau you buat physical examination of the abdomen. And kalau patient tu tak ada rigidity, tak ada rebound tenderness ke apa ke, you still need to mention kan, there's no rigidity, there's no rebound tenderness because that's what expected, especially kalau patient tu presented dengan abdominal pain, for example. And so sama juga macam psychiatry, the patient presented with psychotic symptom. So apa yang you would expect patient ada psychotic symptom? And so contohnya you expect kalau dalam appearance tu ada ada signs of neglect, for example. And kalau patient tu depressed, and you expect kalau dia pernah ada history of self-harming behavior, you expect ada signs and symptoms to show that dia ada marks of self-harm, cutting wrist dan sebagainya. So these are the things that you need to mention. And patient ni ada history of using substance. Apa under appearance yang you nak mention? Negative relevance. Or if ada lah. Apa? Lu, patient ni ada history of ambil substance.
Addictive. Okay, addictive appearance.
Kalau under appearance, you pernah tengok orang tak ada tak?
Dia macam high.
Hai.
So kalau medical kita panggil apa? Signs of intoxication. Okay. Kalau sebut high, then patient appear high. Signs of intoxication. And contohnya kalau opioid intoxication or opioid withdrawal, and so there are specific signs there. And contohnya hidung berair, and pupil pinpoint, and lepas tu sweating for example, slurred speech kalau alcohol. So these are the things yang kita mention dalam appearance and behavior lah. Okay, and then next is speech. And so speech kita mention apa? What do we report on the speech?
The rate of the speech.
Okay.
The rate.
So biasanya kalau saya mention dulu apa language that patient was using, patient's coherence, patient's relevance. Okay. And lepas tu baru kita mention tentang amount, rate, tone. Okay. And so patient was speaking English, and coherent ke tak coherent?
Yes, coherent.
Coherent.
Coherent. Apa maksud incoherent speech? Apa maksud incoherent speech? And what condition do you see in coherent speech?
Coherence means the speech doesn't give any meaning to the listener.
Incoherent. Coherent ni merujuk kepada kejelasan. Okay? Dia tak merujuk kepada konten, tapi dia merujuk kepada cara sebutan itu dilakukan. So that's coherence. So contoh incoherence adalah patients yang ada aphasia, like expressive aphasia. Patient yang ada stroke for example. Ataupun patient yang intoxicated for example. So dia akan ada problem dengan coherence dia. Dan contoh patients yang bisu. And so coherence dia ada problem lah, because you cannot make up apa yang patient tersebut. And relevance ni referring kepada subject to questions yang kita tanya. And so relevant maksudnya dia menjawab. Irrelevant maksudnya dia tidak menjawab. And so kalau patient tu you tanya pagi tadi makan apa, dia jawab saya dulu sekolah rumah merah, dan maksudnya dia coherent, irrelevant. Tapi kalau patient dia kata awak tanya pagi tadi makan apa, dia kata Ifhan, maksudnya patient tu relevant tapi incoherent. Dan sebab dia tak boleh nak sebut ikan, dan dia sebut something else. Tapi dia menyebut ikan. Dan bila dia jawab ikan, maknanya dia relevant. Okay, so itu dua beza dia. Patient can be both, and coherent, irrelevant, coherent, relevant, incoherent, or dua-dua pun tak normal, incoherent, irrelevant. And tapi in psychiatry, generally you would see patients yang irrelevant. Coherence ni biasanya dia relate dengan organic cause. Unless you have patients yang very severely psychotic, you can get incoherent speech. Okay, so that's speech. And then next apa? Next apa?
Rate of speech.
Rate, amount, volume. Was there any abnormality?
I think no.
Normal ke tak normal? Ada kan? So everything else was normal. Then next, mood. Okay. So how would you describe dia punya mood? Doktor tu ada tak tanya specifically mood dia apa?
He did mention.
Tak mention. Tapi generally macam mana you describe dia punya mood?
Down.
Dia nampak macam mana?
Down.
Nampak macam? Down, depressed. Rasa depressed. Depressed ke? Worried ke? Tension. Okay. Saya rasa dia more nampak macam anxious lah, and worried, and risau. Sebab if you think about it, dia rasa tak selamat, dia rasa threatened by the belief and the voices. So that's mood. And then next, perception. And so under perception ada apa? What do you want to describe? Apa yang dia ada?
Hallucination.
Auditory.
Auditory hallucination. Okay. What can you describe about the hallucination? So what type?
Second person auditory.
Second person content. Eh, kenapa ada Prof Ramli?
Kalau masuk ke Doktor?
You ada kelangan Prof
Ada
Ramli
pula
ke?
grup dia kata tak ada.
Sambung. Content
Commentary.
dan content. Commentary. Okay, commentary. Alright.
Commentary.
Ada comment?
No, no
Ada
comment.
comment ke tak? Tak ada comment Okay. So sometimes kita describe juga negative findings, negative relevance. Okay, so auditory hallucination. So that is dia punya perception. And so in this case, they did not explore. Macam I mentioned earlier, like the assessor tu should also assess presence of other form of hallucination lah. So visual, so auditory, tactile, so semua tu lah. Okay, tapi in this case kita assume tak ada sebab dia tak tanya lah. So next thought. Okay, so under thought ada apa? Under thought ada 4 benda. So the first one content. Withdrawal.
Thought
So under
insertion,
thought. Bukan.
thought broadcasting atau control.
Itu thought possession. So under thought ada 4 benda. Okay. So the first one is thought content. Second one, flow. Third one, form. Fourth one, possession.
Form.
Okay. So
Possession.
content, form, flow, possession. Okay. So content, apa yang ada dalam kepala dia. So apa yang ada dalam kepala dia? Apa thought content dia?
Delusion.
Dia ada delusion. Okay, correct. Right. So other examples of thought content macam worries, rumination, homicidal ideation, suicidal ideation. So these are another example of thought content. Alright. Thought form. Okay. Was there any abnormal thought form? Ada ke tak ada? So example of thought form. Apa example of disorder of thought form? Kita belajar kan masa mental state. Apa example of disorder of thought form? Thought form ni maksudnya cara idea dibentuk. Dan biasanya dia akan manifest melalui pertuturan percakapan. So bila dia punya pertuturan dia coherent and relevant, so most likely dia tak ada abnormal thought form. So kalau ada, apa example?
Circumstantial
Apa
thought.
example of abnormal thought control? Okay, so circumstantial.
Attention.
Circumstantial tu apa?
Macam beating around the bush. Macam person answer question tapi tak directly answer question.
Okay, good. So tak nampak dalam ni. So basically apa you tanya dia jawab, apa tanya dia jawab. So there's no circumstantiality. Tangentiality ada?
Tak ada.
Tak ada. So tangentiality ni bila patient dia tak menjawab soalan langsung. So bila patient relevant, so most of the time tangentiality takkan ada. And kalau at the first place you dah describe dia as irrelevant, so there must be some sort of tangentiality dalam disorder of thought form. Okay, and yang extreme tu macam neologism, word salad, so semua tu you would see in patients yang lebih severe. So all of this is also something that you will not be able to memorize or understand unless you've seen one. And so tak dapat tengok in real life, you can always Google, you can always tengok example dalam YouTube untuk you appreciate apa dia punya example. Okay, alright. So saya stop dekat situ mental state, and just to get you some ideas apa yang you nak describe dalam mental state. Maybe last one before kita move to management. What do you think? What's your comment on the insight of this patient?
Patient has poor insight because patient did not think that this is a problem.
So patient do not think dia ada psychiatric problem lah. And pertama dia tak rasa pun symptoms yang dia experience tu abnormal. And second, dia tak rasa pun the abnormal symptoms yang ada tu is due to psychiatric related problem. Okay, alright. So diagnosis kita hari tu apa? Apa kita punya working diagnosis?
Schizophrenic form
Betul lah.
dengan substance abuse.
Substance induced psychosis. So antara substance induced psychosis dengan schizophrenic form, yang mana yang more likely? Yang mana yang more likely?
Mungkin substance induced kot sebab dia memang
Berapa lama dia ambil substance? How long has he been using substance? Dah ada tanya tak? Saya pun tak ingat dah.
Tak ada. Dia tak dia tanya berapa dia
Smoke weed.
Sorry?
Yang speed tu seminggu, yang smoke weed tu dia tak tanya berapa lama.
Okay, alright. So let's say kita assume dia has been using substance for 1 year duration. So dia ada psychotic symptoms for 2 months duration. So maksudnya substance come first, later baru dia develop psychosis. So most likely diagnosis is substance induced psychosis lah. Substance induced psychosis. Alright. So management. So macam mana kita nak manage? So management, bila kita nak manage patient, number 1 kita kena decide treatment setting. Okay, so number 1 kita start dengan treatment setting. Number aim of treatment, what do we want to achieve with the treatment. Number 3, investigation. And number 4, baru kita treat. And so the whole thing tu is kita punya treatment plan lah. Alright, so treatment setting. So treatment setting ada 3. And sama ada outpatient, inpatient atau treat patient in the community. So what do you think? You nak treat inpatient ke outpatient? And why? Patient ke outpatient?
Patient.
Sorry?
Patient.
Outpatient. Kenapa?
Because this final year university student, so we allow worry that if we treat in patient, he will miss a lot of class.
Ya, dia akan miss a lot of class. Dia rasa dia pergi kelas ke sekarang ni? Dia tak pergi kelas dah kan? And sebab dia rasa lecturer dia conspire against him. So macam mana kita nak decide inpatient outpatient? Apa number 1 kita punya judgement kita mesti based on apa?
Based on this patient post harm.
Okay. So kita kena decide based on 3 things. Number 1 is risk assessment. And so risk assessment ni maksudnya sama ada dia kalau kita tak admit ni, adakah dia akan membahayakan diri dia ataupun membahayakan orang lain atau orang lain akan membahayakan dia. So ini 3 benda yang kita kena tengok under risk assessment. So risk to self, risk to others to patient. So kalau risk dia low, maksudnya there's no indication that patient would harm himself, no indication that patient will harm others, no indication that others will harm patient, then it is okay for you to decide patients duduk dekat outpatient for outpatient treatment because risk is low. So you kena ada evidence untuk you justify your treatment plan. Number 2, modalities of treatment. Okay, so kalau treatment yang you nak bagi is something yang you can give as outpatient, then you can give outpatient. Contoh kalau you ada patients yang diabetic, ada cellulitis, fever, and start ada signs of organ failure. So you know you need more than just oral antibiotics. You need to give patient IV antibiotics, patient impending intubation, so you have to admit patient. So sama juga in psychiatry. Kalau you nak bagi just antidepressant, you nak bagi antipsychotic orally, then there's no harm untuk treat patient as outpatient. Tapi if you think patients need haloperidol and then need monitoring ataupun need ACT, then you might want to think about possibility of admitting patient to psychiatric facilities. Number 3, apa number 3? Aku fikir sikit. Apa number 3? Apa lagi indikator yang menyebabkan you rasa, oh, kena masuk ni, buat patient ni dalam ward ni, kalau tak boleh jadi ni.
Compliant to medication.
Compliance tu saya letak dalam treatment modality, tapi betul, that's one of the indicator. Lagi?
Severity.
Apa?
Severity.
Severity. Bolehlah juga. Okay, lagi? Itu biasanya kita assess dengan risk assessment lah. Kalau kita dia maknanya high level of support. Okay, so level of support. So for example, if you have patients yang psychotic, tak makan tak minum ke, tapi you have a family yang very supportive, akan jaga ubat dia, tolong pastikan dia tak buat benda-benda bahaya, bawa dia for next appointment, then it's probably okay untuk you treat patient as outpatient. Tapi kalau you ada patient yang duduk bawah jambatan, yang you pun tak tahu kalau you discharge patient ni, patient akan buat apa dengan ubat ni, nak makan dekat mana, dia ada duit pula nak datang untuk next appointment, follow up, and so you might want to consider inpatients. So you have to look at these 3 aspects before deciding sama ada patient ni suitable to be treated as outpatient or inpatient. Alright, so second, aim of management. So aim of management ni standard lah. And so aim of management ni kita talk about what do you want to achieve by admitting patients. So biasanya kita nak reduce the symptoms, kita nak improve patient punya function, kita nak regain patient punya premorbid state. Okay, so that's kita punya aim of management lah. Alright, so investigation standard lah, biopsychosocial. So investigation you look into 2. Diagnostic investigation, baseline investigation. So diagnostic investigation, role dia untuk you rule in, rule out you punya diagnosis. Contohnya, one of your differential diagnosis is substance induced psychosis. Then investigationnya apa?
Urine analysis.
So urine toxicology. Okay. And so maksudnya urine toxicology itu is one of your diagnostic investigation. And so contoh baseline investigation, you nak tengok dia punya liver function, you nak tengok dia punya renal function, sebab you punya medication will be metabolized in the liver, will be excreted in the kidney. And so you want to know these 2 organs punya functioning level, and so that you boleh decide. Sekejap ada phone call. Hello, Assalamualaikum. Bro, yeah. Alright. Kita kat mana tadi? So investigation lah. So that's bio, psycho, social. So for biology, so all the bloods, urine, semua benda tu lah. And so untuk psychological, biasanya psychosocial lah kita letak sekali ya. And so for example, things that we look for adalah number one is any questionnaire yang look specifically into dia punya condition lah. And so contohnya kalau depression, back depression inventory, DAS for example, hospital anxiety depression scale, HEARTS, brief psychotic rating scale, BPRS. So these are some of the examples. Nanti next year bila you all buat PhD nanti you all akan being exposed to further example of this. So that's an example of psychological. Another example of psychological macam IQ test if it's necessary, alcohol withdrawal assessment scale, and so that's kita panggil psychological investigation. Okay, personality test if it's indicated lah. So these are generals and tak semestinya semua every single patient psychiatrist itu kita akan buat lah. And so contoh kalau children kita nak diagnose intellectual disability, and so kita punya screening tools, kita IQ test semua tu duduk dalam psychological test lah. Tapi kalau adult datang for schizophrenia, kita tak buat IQ test. There's no indication unless one of your differential diagnosis is patient ni ada disorganized behavior and you thought the disorganized behavior ni could be intellectual disability. So that's probably apa namanya one of the reason why lah. That's one of the reason why it's indicated. Okay, alright. Saya ada 1 minit lagi. And then management. Alright. So for management, so sama juga bio, psychosocial. So for biological, and we mainly talk about medication lah. So in substance use psychosis, there are 2 options. One is you don't treat with antipsychotic, you let time takes it course. Maksudnya once dia punya substance tu reduce from the system, and dia akan improve. And tapi some patients substance tu banyak, you take times, ataupun patient terlalu aggressive, terlalu agitated, menyebabkan you need to give something apa namanya, you need to give something now untuk reduce the symptoms. Then you give patients antipsychotic. Another thing that you can give kalau patient agitated, kita give benzodiazepine. So those are management for patient presented this way lah. And so like this case, for example, you can choose any antipsychotic, olanzapine for example. So give olanzapine 5 mg on night. Patient nampak agitated, tak boleh tidur, you bagi benzodiazepine, and you choose anything. Contohnya diazepam 5 mg on night. And so those are your management. Okay, alright. I'm so sorry, saya kena stop abrupt. Saya kena masuk ada online session. Kita stop dekat situ dulu. Next week you ada lagi kan?
Ada last week.
Ada. Okay. So next week kita arrange another session lah untuk discuss different case. Alright, thank you. So, carry on with your homework . Untuk besok punya seminar nanti saya bagi link to my lectures lah. And so tengok lectures dulu so that dalam kelas kita discuss saja. Alright?
Okay,
thank you. Assalamualaikum.
Doktor, thank you doktor.
Thank you.
Thank you, Doctor.
Salam.